I would like to extend a warm welcome from Tufts Medical School and Medical Center to Dr. Jerilynn Prior. We welcome her today to explore the topic of very early perimenopause. Dr. Prior is a professor of endocrinology and metabolism at the University of British Columbia in Vancouver. She has spent her career studying menstrual cycles and the effects of cycles changing estrogen and progesterone hormone levels on women's health. She is the founder and scientific director of the Center for Menstrual Cycle and Ovulation Research, CMCOR, and also the director of the BC Center of the Canadian Multi-Center Osteoporosis Study, a large population-based cohort study. Dr. Prior has studied women's menstrual cycles, perimenopause, menopause, and the causes for and treatment of osteoporosis. She has shown in controlled trials that the ovarian hormone progesterone is effective treatment for perimenopause hot flashes and flushes. A completed RCT also documented improved perimenopausal night sweats. Dr. Prior is here now for her Boston University School of Medicine 50th reunion. She moved to Canada in 1976 and became a citizen because she believes in the Canadian universal healthcare system. A warm welcome.
Delighted to be here to talk about a rather peculiar and not so popular, whether you're a midlife woman or a person of any other age or any gender, which is about perimenopause. It's sort of the lost period in the middle of women's lives. And we're talking about the very earliest part of it, which isn't currently recognized. So first of all, I'm a faculty member at the University of British Columbia in endocrinology. I don't have any conflicts of interest with for-profit entities, and I want you to understand that the contrast in the ancient Gary oak here and the new blossoms in springtime captures the paradox of perimenopause, which is both about maturing beyond our reproductive years, but about a new phase of our lives. So we have all kinds of different names for women's midlife, including this pejorative one from Dr. Edward Tilt in the 1780s, decline of life. But there's controversy in almost all of these names. And one of the big messages I'm here to say is women need to be heard. So when women say, these are my experiences, physicians in particular need to say what could be causing that, not she's a bit out of it or whatever. So we're going to talk about current concepts of perimenopause and menopause. We're going to talk about the hormonal changes that occur and the experience changes that occur. And then we're going to try to figure out a way, which I've been working on for years, to define the time of life when everything's changed except periods, which is what I mean by very early perimenopause. And finally, if we do make a diagnosis and they're miserable and need treatment, what are the effective treatments? So what are the current concepts? Well, I graduated from medical school in 1969, and menopause was estrogen deficiency. It was all about dropping hormone levels and, shriveling up and getting old and ugly. And there's still a lot of that cultural concept in our society. So the idea of declining is there. But because it was such a amorphous area and there were so few criteria, there was initially in 2001 and then 10 years later a conference to try to define, and they called them stages, which sounds more like a machine than it does physiology, but stages of reproductive aging, or STRAW. And define the different phases of women's reproductive lives. So the straw criteria are anchored around this, FMP, which interestingly isn't very well defined, but is the standard doctor talk for final menstrual period. And the final menstrual period, or menopause in many gynecologic speak, is here, and following that is early menopause and also postmenopause, but it's also that first year still perimenopause. So this is a nonsensical, overlapping categorical system. But the definition of perimenopause is menstrual cycles that vary persistently, more than a week, one cycle to the next. And the earlier than that is a big black void. It's supposed to be life as usual. So we think that estrogen levels are dropping and women are becoming estrogen deficient. But let's talk about a woman first. And this, I've made up this story, but it's so typical. So she's 41, and she's the married mother of two, both now teenagers. She works as an office manager, and she is having horrible flooding menstruation. She bleeds so much that she gets dizzy when she stands up. And she's been waking at night sweating. Okay. In the sort of categories that I grew up with, heavy flow means high estrogen, and night sweats mean low estrogen. Therefore, this does not compute, if you will, for the average medical practitioner. So, what are the typical hormonal changes, and then we'll talk about experience changes, in this early period of perimenopause? Well, first of all, we have to start with a gold standard. Whenever you're comparing something, you have to know what you're comparing with. And the gold standard is the normal menstrual cycle in a premenopausal woman. And this is just a diagram, typical one from the internet. So here, estrogen is in this bluey color, comes to a mid-cycle peak, triggers the luteinizing or LH peak, which then triggers ovulation. Then progesterone here in red starts to rise. And if you look at this diagram, you would say, okay, well, estrogen and progesterone are made in about the same amounts in the menstrual cycle, and progesterone is there for only half of the time. Well, that must be what's happening. But interestingly, that diagram, though it looks very scientific, had no units on it. If you put estradiol and progesterone in the normal menstrual cycle, flow starting here, the next flow starting out here, estradiol rises from its low during flow about 240% to that mid-cycle peak. It drops down again, and then there's 100. It rises about 100% in the middle of the luteal phase after ovulation. But progesterone rises 1,400% from its baseline during flow. How can that be? Because estradiol is reported in picomoles and progesterone is reported in nanomoles. And the nanomole unit is 1,000-fold bigger than the picomole unit. So our understanding about the menstrual cycle is biased toward estrogen by the way in which we depict it commonly in the internet. digress a little bit here. I was, happily going along with a regular period, and I started having very heavy flow. The thing that bothered me most, though, was my breasts were sore and bigger and lumpy. It was very scary. And I went with sore breasts for years. And I said to myself, this is crazy. How can I be having low estrogen and sore breasts? Doesn't make sense. And I even had a dream, a very vivid dream, that I was pregnant. I thought, what? I once reported it when I was giving a talk to a lay audience. So I talked about this dream, and somebody in the back of the room hollered, "That's not a dream, that's a nightmare." And literally, it would have been a nightmare because my kids were getting bigger. That, clearly that part of my life was over. Okay, so I began to start to investigate. What does the literature say? And all I could find was this dropping estrogen story. It was really very consistent. And I started to try to figure it out. And actually, one of the things that sort of told me I wasn't making it up or it was real is that I found a very old paper on Hodgkin's lymphoma, where the woman had lymph nodes that were abnormal in her pelvis and got irradiation for the cancer in her pelvis. And they showed her hormone levels. And she had sky-high estrogen. And I said, yes, the ovary was damaged, but in its damaged or older state, it was making more estrogen, not less. And so I want to show you what I kind of figured out. And it took me quite some time to figure it out. So I made it into a kind of a cartoon. But early in the follicular phase of the menstrual cycle, there are signals in the brain, in the pituitary, and 2 ovaries that are full of eggs, full of follicles, each of which has a potential egg for ovulating. And the typical story is that one follicle is near the outside edge, it has more receptors, it starts to grow, it grows bigger, there's some crosstalk hormones that aren't in the circulation that say, okay, it's my turn. That's what the dominant follicle says. It makes the majority of estrogen. It feeds back, and plus a hormone that I hadn't heard of before called inhibin then shut off the pituitary so that the follicles don't keep getting stimulated all out of kilter. So that makes a lot of sense. And there's feedback that's essential in the normal menstrual cycle between inhibin and FSH. But I think, and this was a hypothesis then, I published this paper in 1998, that as the ovary gets older, there's less inhibin made by the granulosa cells in the follicle that holds the egg. Less inhibin doesn't shut off FSH completely anymore, and there may be some other local hormone changes. So there's a potential to stimulate more follicles each month in this growing cohort, and even the potential to have more than one dominant follicle, which is why older mothers typically, if they have twins, have non-identical twins. And so this would be an explanation for how estrogen could rise in perimenopause when there are fewer eggs altogether. And it turns out that, yes, we know that there's decreasing numbers of follicles in an ovary. These are all from an autopsy study. But what's interesting is that if you look at the slope of the line here, and then you look at the slope of the line here, where they cross is about the late 30s. And that is around the time when the earliest time, when some women start becoming symptomatic in very early perimenopause. So I think of perimenopause as the ovary's grand finale. It's like a fireworks show, you know, you start with one lovely Roman candle and then it's something else and different colors. And toward the end of the fireworks, it's boom, 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 boom. It's just, you know, a blast at the end. So this is the ovary's grand finale. And in a way, it makes some sense because it's trying to get all of the potentially stimulatable follicles done so that at 80 or 90, women don't have periods in nursing homes. It's trying to clean out, to get rid of, to get ready for a new phase of life. Well, that idea that high estrogen could be produced in perimenopause as part of this whole process of getting older, reproductively older for women, was just unthinkable in the 90s. Even in the early 2000s, there are many doubters still. But the first and most courageous identification was from a cross-sectional study done by Nanette Santoro. She looked at women she did daily urines in women who were premenopausal and in women who still had regular cycles but whom she called perimenopausal. They had night sweats or they had something else that brought them to her attention. And this is an estrogen conjugate in urine, and I think you can see the open circles are much higher than the solid circles in a normal menstrual cycle in length. And look here at progesterone, the open circles are very low compared to the premenopausal woman. So not only is estrogen higher, progesterone's lower. It turns out that there are multiple feedback processes that can be disturbed and variably disturbed in perimenopause. You can't count on an estrogen peak stimulating an LH peak, for example. And even when you have both estrogen and LH peaks, you can't count on that being followed by ovulation. And the high estrogen is not reliably able to shut off that follicle-stimulating hormone. So the things we think of as invariant in ovarian physiology all of a sudden aren't. All bets are off. It even becomes so chaotic that, let me just show you 2 cycles in a row. Here's one woman's cycle, and it's a typical early 26-day cycle. Again, these are urinary hormones, estrogen now in the solid dots and progesterone in the open circles. So that's a normally ovulatory short cycle. And then, here's a long duration of early follicular phase. Finally, estrogen levels get to another mid-cycle peak. There's finally some progesterone, ovulation, and then estrogen goes crazy. It goes back up again. And in fact, it makes my breast sore to think about it. It's so high. And it's still high at the time when flow starts, which, by the way, a very old researcher on perimenopause or menopause says is associated with heavy flow, to have a high estrogen at the time that flow starts. This cycle has a very puny ovulation if you compare it with here, but you would say still that was an ovulatory cycle. That's called luteal out of phase events. I want to show you these data because they're important, both in my understanding of what was going on, but also, and because they were the first, actually, but also because it helped me to understand how hard it was for doctors to see something they didn't expect to see. Henry Berger is a a very prominent reproductive endocrinologist from Australia. He worked with Lorraine Dennerstein, a very good scientist and psychiatrist, actually. And they did a population-based study in Melbourne. Random sample using the voter registration list of about 400 women. They were 45 or older. They still had menstruated within the last year. They had their uterus and they agreed to be in a longitudinal study. So what they decided they would do was measure hormone levels early in the follicular phase each year for each of those women over time. And when they started measuring the hormone levels, they didn't know how to categorize the women. And so they said, okay, we'll break them down. We'll call those with regular cycles premenopausal, and those with changes in cycle length here, number 2. Number 3 were changes in flow, and that could be heavier flow or lighter flow. Changes in both flow and cycle length here, and those who were 3 to 12 months, actually, since their last flow, who might be very close to menopause. And basically, they published these data and said, you see, estrogen levels drop between those women with regular cycles and those who were almost a year since their last period. And statistically, that is correct. But I've altered this diagram by putting this line across here, because that's the line around which normal premenopausal women's estrogen levels should cluster. And this line is the line of the average mid-cycle peak in Dr. Berger's lab in premenopausal women. And now when you look at it, I think you can see that there's a lot of dots that are each dot an individual woman's data, that are a lot higher than even the mid-cycle peak. And they were all done early in the cycle. So when I saw these data, I said, yes, I knew exactly what it showed. But when I read the summary in the abstract, this says dropping estrogen levels. And I was so angry, I phoned Australia. I got the poor statistician, and she said, I just did what he told me to do. You know, I did the mean levels in each of these groups. But because he did not expect to see high levels, he couldn't see it in the data. Well, I was on a mission to try to understand what was going on. So I began to look for data that had been published that had pre- and perimenopausal women with hormone levels early in the cycle or late in the cycle from the same center, because one of the problems is that estrogen assays differ in different centers. So using these paired data in a kind of a meta-analysis, I could say, are the premenopausal levels different than the perimenopausal levels in the follicular phase? And it turns out they are statistically different. How about premenstrually? Some of these would be ovulatory and some not. Again, statistically different. And for the average woman, we assume these were not highly symptomatic women, it's about 30% higher. Not the double mid-cycle peak level that we saw earlier, but about 30% higher. So I hope you will agree with me that estrogen's higher in perimenopause than in premenopausal women. What about progesterone? And I'm showing you just one person's data here. And it's highly unusual to do a study of one. But if you look at cycle length, luteal phase length, it's statistically significantly different over 10 years. These were when she was in her mid-30s. each blue bar is the cycle length, and I think you can see she has regular cycles, around about 28 days, 29 days in length. The yellow bar is the luteal phase length, and 10 in this system is the normal lower limit. So in one cycle over 14, she had a short luteal phase, but the cycles were regular. And the study was over 1 year with 2 screening cycles. But years later, she wrote to me. Can you imagine a postal letter in those days? She wrote to me and she said, you know, I'm having trouble with heavy flow. And I'll never forget her because she wrote in her letter that she had a new special guy in her life. And she said, I can't cuddle without a puddle, which is apt, I think. Anyway, so I called her up. She lived up the valley from Vancouver. And I called her up and we chatted on the phone, and it turned out that she'd been continuing to keep the record she'd kept during the study. And so I said, could you send them to me? You know, I think I can help you better if I understand. So she sent me the data and we plotted it out over the same season changes as here. And I think you can see that she still has a regular period. Statistically, her cycle length is now shorter than it was before. And I think you can see that most of the time she's ovulating, but that not a single time over these 14 cycles did she ovulate with enough progesterone, long enough progesterone exposure. Are still regular, although shorter than they were 10 years before, and that she's still ovulating most of the time. But in cycle 2 and cycle 13, she didn't ovulate, and not a single one of these cycles is normally ovulatory. All of them have too short luteal phase length. So then another question, and this is something that patients would ask me, why do I feel so stressed or anxious in perimenopause? And I puzzled over this, but then I found this rather wacky study. There is a social stress test that was created by scientists at Trier University in an old Roman town that's on the edge of France in Germany. And what they would try to find out how a person's hormones and how they reacted to a social stress which involved speaking in front of an audience, a critical audience, and doing math in front of an audience, which that would destroy me. But they decided they wanted to see whether or not estrogen contributed to the stress of this, this challenge. So they enrolled young, healthy men and randomized them to wear an estrogen patch or a placebo patch, and carried on with the standardized stress test, bringing them in 24 to 48 hours after they put the patch on. And here are the results. So we're looking at the men who were on the placebo with open circles, the men who had the estrogen patch with dark circles. So this is ACTH, the pituitary hormone. Here's cortisol, which is the adrenal stress hormone. And here's norepinephrine, which is the sympathetic hormone. And these were statistically significantly higher peak stress responses. The area under the curve was significantly higher here for norepinephrine. In other words, it has a similar pattern of stress response, but it's amplified by the higher estrogen exposure. Okay, so in summary, we've talked about the coordination and the feedback system being out of kilter, about estrogen being higher, about progesterone being lower, and about the stress hormones being higher as estrogen is higher and amplified by stress. And how does that affect women's lives? It changes everything. And it changes everything in ways that are often difficult to describe or explain. And especially when it isn't something you or your doctor or anybody else expected. The big ones are this night sweat business, trouble sleeping, difficulty coping, heavy flow, becoming anemic. But there are some really weird ones like nausea, being pissed off for no reason at all, just suddenly out of the blue angry, being anxious, feeling like the big one is having trouble coping. Women who've just been, organizing everything in their lives, doing 10 things at once, doing it with grace and dignity and efficiently, all of a sudden, one thing, and they fall apart. And this is hard to explain. How do you go to your doctor and say, I can't cope? Luckily, and this is a guess because no one is tracking this yet, I think only about 20% of women have a difficult time. And I remember very well that when I complained to my mother's cousin, kind of a heroine of mine, that I was having such a rough perimenopause, and she said, "You were meant to have a tough time to figure it out for others." I said, "Gee, thanks." Anyway, okay, so how do you capture those experience changes? It turned out that I had created a diary for the study, the woman I showed you before, for whom we had data over 10 years. I created a diary that had normal experiences in it and reproductive experiences in the menstrual cycle. And I simply altered that diary so that I added night sweats, both the number and the intensity, and daytime hot flushes, number and intensity. So we had a way of recording the experiences of women with regular cycles who were still premenopausal and those for whom things had changed. So here's the diary, and I know you can't see it very well, but it's available online, and also something that's now old, but a video of me trying to explain how to keep the diary and explaining why things were changing, the puzzle of perimenopause. So we know how the hormones change, how experiences change, how the society looks at it. The question is, can we figure out a way that makes sense to give women for whom everything's puzzling, but whose doctors can't hear what they're trying to say, can we give them and give ourselves a way of making a diagnosis when everything has changed except periods? Well, so let's go back to the woman we started with and get a better history. She says, I've always had perfectly fine periods. I had no trouble with getting pregnant or childbirth. My cycles are still regular, but they're shorter. Now about 24 days apart. And when I bleed very heavily, especially early on in the cycle, and then I carry on bleeding for another week or so, sometimes. And what really worries me is when I'm bleeding heavily, not only do I start, soiling all my clothes, but I really feel woozy, weird, dizzy when I get up or sit up. She also said, my cramps have gotten worse in the last year, and they'd gone away since I had my first kid. Now they're worse again. I don't understand that. And she described a typical thing of waking early in the morning, feeling anxious, and then having a wave of heat and sweating. So the doctor quite rightly measures some things, measures her blood count, which is low, measures her ferritin, iron stores in the bone marrow, and that is also low, suggesting she's been having heavy flow for some time. Does a pregnancy test, because heavy flow could be early pregnancy or a miscarriage, and measures the quote menopause hormone, FSH, and it's quite low. It's a perfectly premenopausal level. So what is the doctor going to tell her? You're not in menopause because your FSH is normal. Straw says you have to have irregular cycles before you can be in perimenopause. Okay, let's back up again. I wanted to tell you that there's even something more peculiar about the hot flushes and night sweats that when they first start. This is using the diary. So here's flow. You can see the number of days and the amount of flow here. So just translating from the diary. Here's daytime hot flushes, and she has only very mild and very few. But here are her night sweats. And look at them. Every single time around a period, she gets night sweats. And that is weird, especially when they're not happening in the daytime. And her sleep doesn't correspond very well at all. She has sleep trouble all over the shop, not in a cyclic pattern, but her night sweats are strange. So that says to me there's something neuroendocrine, basic physiology that's changed. She wouldn't make that up. And this happens to be a familiar pattern. I used to be able to predict when my period was going to start by having a night sweat before. So I think we need to give her a diagnosis. And she doesn't meet the criteria for the early menopause transition or the late when you've skipped a period. So although very early sounds like it's too early, very early in perimenopause seems to be an appropriate name for this phase when everything's changed except cycles. So I basically took a bit of a page out of the rheumatology way of making a diagnosis. They will say you have lupus if you have these 3 criteria. You know, often in rheumatology they have some biomarker that's elevated. In this case, we don't have a lab test that's reliable, in part because estrogen is swinging so widely. So a single estrogen level can be low, can be high, or in between. So you can't use estrogen for a diagnosis. But if you take all these 9 things that are pretty typical of the changes women report, and women say, I have 3 of them. So she had heavy flow, she has a shorter menstrual cycle, she has trouble with her sleep, she has cramps, and she has night sweats. So we can use those clinical signs to make a diagnosis of very early perimenopause. And I think we need to. So how are we going to treat her? Well, the typical treatment for hot flushes, night sweats is estrogen-based. And often, and I think where I come from still, birth control pills are the go-to therapy. 1, they're going to prevent pregnancy or unwanted pregnancy. 2, doctors are very familiar with them, but there's good data that birth control pills don't work in perimenopause. Even a good randomized controlled trial. Well, what does her doctor tell her? Now this is a holistic doctor. So you need to exercise, you need to eat properly, you need to decrease your stress. You're probably in perimenopause, I don't know, don't know for sure, but it's normal. You'll get over it, go home, which is not acceptable to most women. It isn't simply acceptable. It's helpful if someone says, yes, I know what's going on for you, here's the timeline, here's what I expect will happen. Having a diagnosis is helpful, rather than somebody saying, you know, you're just a pain in the neck or it's all in your head. But being told to go away and you'll get over it is not sufficient if someone's just about ready to quit their job because they can't manage. All right, so I did that big review and worked on the definition and the hormonal changes in perimenopause, got it published in a very good endocrine journal in 1998. And I found I wasn't even allowed to teach about perimenopause at my own university. We knew what was going on. There was a week on menopause and that was it. Mostly they learned about, quote, HRT during that week. And when I went and talked to the head of that course and said, did you mean to skip the P word on purpose? The perimenopause on purpose? You know. So I realized that my patients were not getting any help at all. They were still getting brushed off or given a psychiatric diagnosis or given a psychiatric drug. And so I did a very strange thing, which is to write a novel. My first degree was in English. I like to write. I've been listening to women's stories for many decades. So I made up 8 different women, and I made up a doctor. And these women come to see the doctor, and they interact with the doctor, and life goes on, and sometimes things help, and sometimes they don't. But the doctor and the woman were working together by and large, and that's what counts, is a doctor who listens and a doctor who tries to figure things out with the person. So this is now in a second edition as a ebook. All of the royalties, since it was originally published in 2005, are going to the Center for Menstrual Cycle and Ovulation. And from the letters and emails I've gotten, I think it is reassuring to them to have somebody they recognize, someone else whose story is like theirs. So I think what is missing in perimenopause, what is low in very early perimenopause, is progesterone. And it makes sense to use progesterone. Sometimes the symptoms will be premenstrual primarily, the sleep problems, the night sweats, etc., and cyclic progesterone works. Sometimes it doesn't. So basically, for the 2 things that were her main problems, heavy flow and night sweats. The heavy flow, and every woman ought to know this, ibuprofen, the ordinary, it's got a million different brand names, you can buy it at any drugstore, is somewhat effective for heavy flow. It statistically, by the meta-analysis that Cochrane did, it decreases flow by 20 to 50%. 200 or 400 in perimenopause, I would say 400. 2 tablets with each meal 3 times a day on a heavy flow day is absolutely important. Carry it. I used to tell my patients, don't go anywhere without it. And if the heavy flow persists, then progesterone needs to be given daily. And it needs to be given for a long time, because by that time, the uterus has been exposed to a lot of high estrogen, and it takes a duration of progesterone in a normal dose to deal with the heavy flow. The dizziness during flow means volume depletion. So salty liquids, bouillon, salty soups, Clamato juice, those kinds of things are very helpful. And although often doctors forget to say this, by the time you have anemia, your ferritin is low, it takes a year of daily iron tablets to replete the bone marrow iron stores. So buy enough for a whole year and keep taking them till they're gone. Now, night sweats are really puzzling. They're that cyclicity I talked about. And one of the benefits of progesterone is that it helps with sleep as well. So I had already done a randomized controlled trial showing progesterone was effective for both day and nighttime vasomotor symptoms in menopausal women. And I finally got the funding to do a randomized controlled trial in perimenopausal women. And I'll show you some of the data. It's not yet published. I did present it at the Endocrine Society in 2018. So this is a question in which we asked women, and they were blinded, at the end of the trial, how have your hot flushes or night sweats changed? So we're looking at daytime ones on this side and nighttime ones here. We're looking at the placebo here and active progesterone with the blue for the median line here. And the overall change in night sweats was statistically significantly improved in those on progesterone. But we asked them also, how about the frequency, how often you get them? For daytime hot flushes, it wasn't quite significant. For nighttime ones, it was significant. And how about the changes in intensity? How hot you get, how sweaty you get. And here, both daytime and nighttime hot flush intensity was statistically improved when we asked women to assess the change. So here would be my summary of what helps. And for much of this, there isn't a randomized controlled trial. It's based on clinical and personal experience. So the important thing is to realize that this is not old. This is not the end of your productive, your attractive, your sexual, your what you value in life. It is a transition, and transitions are tough, but it's not old. And I don't know anybody nowadays who would die in perimenopause. You will survive. And that's a good thing to remember. But I really do think that in spite of the pressure from partners and doctors and society that estrogen is going to make everything better, avoid it in perimenopause, because we can't be sure that it would be safe given that your own estrogen is flying up and down. Now, that's a weird thing to say. Take care of yourself. Why? Because our culture, the Western culture predominantly, says our job is to take care of other people. So we've made it a good job. Most of us have taken care of a lot of others. But in perimenopause, we need to say, I'm sorry I can't be on that committee anymore, or I'm afraid I can't, organize that potluck or this, talk or this meeting or whatever it is. Say, maybe in a few years, maybe when I'm feeling better, maybe when my life is organized better, but take some time out. Walking or exercising, doing something regularly is helpful. It's probably important for metabolic reasons, but it's certainly important also for emotional, psychological reasons, and it may prevent some of the excess weight gain that can occur in perimenopause and lead to things like diabetes. Now, I talked before about the estrogen amplification, but we can decrease how we react. So there's a whole bunch of different tools that have been used, a whole bunch of different religious ways of coming at the same thing. Whatever you choose, you need to practice it so it's in your tool chest when you need it. Now, midlife, in fact, paradoxically, with the estrogen going up and down, even though the average is high, bone loss starts in perimenopause. So there's a number of things that you can do to help your bones. One of them is increasing vitamin D. There's an online article on the Semaphore site about that. And then progesterone if needed. I did publish this in a strange OBGYN journal a few years ago, and that in that journal I was trying to get the big picture rather than to give a whole mess of science data. We have more data now than we did then, but I think the big picture holds, and that is that estrogen needs counterbalancing by progesterone. So the good news is that it's often a very long period of time. For me, it was at least 10 years of changes in which there are marks of progress. So for me, it was good when I started having irregular cycles. And I rejoiced when I skipped a cycle. And it is a time for real celebration when you've been a year without a period. So we all can graduate into menopause, and then this phase of our lives is put to bed. So we need to listen to women and put women into straw, and be sure to remember that there are times when our concepts may do a disservice to women if we're not listening and trying to figure things out for them. So I would be happy to take some questions, and then I'll summarize. So we've talked a lot about a lot of pretty complex physiology, and it's a little bit disturbing to have concepts and labels and things you thought you knew that are sort of turned upside down. But I'm hoping that you now understand how quite different perimenopause is from menopause. In the words of an old Brit woman that I took care of some years ago, she said, "They're as different as chalk and cheese." So perimenopause is really what people are talking about when they make out that menopause is so horrible. They're talking about the chaos of perimenopause, really. So a combination of things that are peculiar when put together, night sweats, heavy flow, sleep problems, mood stuff, are all characteristic of perimenopause and associated with higher and swinging and unpredictable menstrual cycle, unpredictable estradiol levels, but there may not be unpredictable periods for the first while. It's important to know that. It's important to listen when women give you this kind of a complex story, and to not abandon them to no therapy. And finally, it's useful to know that there is something for which there's evidence and that makes physiologic sense that can help women who are having a difficult time in midlife. Thank you very much.